welcome everyone to Hour with the Expert. My name is Jennifer Craig. I am an educational consultant from Patton West. I believe we have Sue Ann Hauser and Aaron Campion, both educational consultants to help in the background. Today, we are very fortunate enough to have Dr. Nicole Corbin from the University of Pittsburgh, who's in the Communication Science and Disorders Department, who is a clinical instructor and also is supervising the the audiology students at the University of Pittsburgh. Any questions today, if you wouldn't mind putting them in the question and answer. Nicole will get to them at the end of her presentation. And it's being recorded today. We also have the transcripts available if you want to turn them on. You can also utilize those. And that's it. Welcome, Nicole. We're so happy to have you.
Thank you so much. It's so great to be here. It's such an honor. I'm going to go ahead and share my screen here. Okay. So as Jennifer mentioned, I am at the University of Pittsburgh in the Department of Communication Science and Disorders. I'm also the audiology faculty member and co-principal investigator for the audiology supplemental training grant that we have under the Leadership Education in Neurodevelopmental and Related Disabilities, or LEND program. And I encourage you all to check that program out. It could be a really helpful, useful resource for families and professionals alike. So today we're talking about pediatric unilateral hearing loss. And to start off, just wanted to do a brief overview of what that is. So most recently, the definition that's been applied is any degree of permanent hearing loss in one ear. And this has been suggested by some clinical practice position papers and guidelines to mean a pure tone average, or the average of the thresholds in one ear at 500, 1000, and 2000 hertz of greater than 15 dB HL, with the addition of normal hearing in that opposite ear. There are a few different definitions of unilateral hearing loss out there. This one here has been the most recent one used, and so that's what I went with today. You might see something along the lines of pure tone average calculated at 500, 1000, 2000, and 4000 hertz. You might see that threshold cutoff at 20 dB HL as opposed to 15, but this is the one that's most recent for today. So some statistics about unilateral hearing loss. In general, we know that permanent hearing loss is present in about 1.5 to 3 or 4 per 1,000 births, depending on what you consult. And permanent unilateral hearing loss, the prevalence of that will vary depending on the definition of hearing loss that's applied. So knowing that, we can estimate that about approximately 1 per 1,000 infants would qualify as having permanent unilateral hearing loss based on newborn hearing screening results. We see that number jump up by the time children get to school age. So in that population, we have our prevalence of about 3%, and it's also been cited up to 14%. The caution there is that a broader definition of unilateral hearing loss was applied for those data specifically. And so I think a more maybe accurate estimate or conservative estimate of 3 to 10% in that school age population would be more comfortable. About a third of children with UHL have been reported to fail at least one grade or be kept behind a grade. Over 1 in 5 have persistent academic or behavioral challenges. And it's not very, it's becoming more common, but in the past, many studies have shown that Amplification often is not initially recommended for infants who are diagnosed with unilateral hearing loss at birth. So we know through the EDDI program, early hearing detection and intervention programs, that we have a more rapid identification of hearing loss in children. That leads to a more kind of timely intervention through that EDDI system. For kids with unilateral hearing loss, we might be identifying them and diagnosing them earlier in life, but we don't often hit that 6-month EDDI benchmark of intervening early on with amplification or other devices. And for those children who end up using a device, we see that there's really inconsistent use. About 50% of them might use it consistently. That could range hopefully up to 70%, but we still see a lot of variability in acceptance and then consistent use of that device. So I want to review some challenges or some difficulties that unilateral hearing loss in childhood has been associated with. A lot of these we have been just building evidence for the past, well, back in the early 80s is when we kind of started getting this information. And since then, we've just been building on this evidence base showing that actually these children do have some difficulties. It was thought in the past that they had one normal hearing ear, they're going to do just fine because they typically acquire speech and language seemingly appropriately, right? However, as the evidence accumulates, we're seeing that there are some subtle difficulties. I'll review them here, but I don't want to focus so much this talk and our conversation on those difficulties. So I'm not going to, my talk will kind of go into a different area today. So some known challenges. Children who have unilateral hearing loss often have difficulty understanding speech in complex listening environments. So when you have hearing in both ears, that really is helpful for receiving a target signal of interest. So for instance, my voice, a teacher's voice, a parent's voice, and understanding that signal that we're hearing and being able to ignore any background noise that might be in the environment. When we have unequal hearing or maybe hearing only in one ear, it can be very challenging to understand that target speech when there's background noise. We also can experience difficulty figuring out where sound is coming from. And this has some consequences or some implications for safety. So we use information coming to both ears to figure out where a signal is coming from. There is a lot of variability in the speech and language outcomes noted among this population. I'm going to review some that have been noted as showing difficulty, some areas. So children with unilateral hearing loss have been shown to have difficulty acquiring morphemes, difficulty with narrative skills, verbal reasoning, early language development, so morphology, picking up that plural S versus the singular form of a word, phonological processing, and then comprehension, and non-word learning and categorization of if a word is a word in my language or not. So the key thing to kind of think about when we look at all this information here is that, one, there's a lot of variability in outcomes, and two, some children are going to have difficulty with these. And so it's really important that we keep an eye on the development of children in those early years, from infancy all the way through school age, to make sure that they are keeping on track and we're seeing the expected development relative to their peers with typical hearing. More recently, we're seeing a lot more information about the effect of unilateral hearing loss on children's ability to pay attention for prolonged periods of time. So that might be throughout the school day and then after school during activities or coming home. A lot of children are experiencing what we call listening related fatigue. So just fatigue associated with listening for so long and having to attend and in the presence of these other difficulties that I mentioned previously. Expending a lot of effort can lead to fatigue. So listening effort kind of goes hand in hand with that. Social emotional skills have been shown to be a challenge among this population as well. And then functional auditory skills as assessed by parent reports, meaning that if I give a parent a survey that asks them to rate how their child does on various tasks or things throughout the day, and the parent writes, they experience a lot of difficulties or they don't experience any difficulties at all, I can take a look at the overall measure that I've given them. And the parents of children with unilateral hearing loss often report their children experiencing more difficulties in their everyday environments than those children with typical bilateral hearing. More recently, we're also seeing there's more evidence accumulating, especially in the past couple of months. There's been a few studies coming out showing that the quality of life of children with unilateral hearing loss can either, one is poorer than children with typical hearing in both ears, and two is similar to that of children who might have bilateral hearing loss. And you want to kind of interpret those findings cautiously. A lot of the quality of life scales that are used can be a little bit problematic. There are some really good hearing health related quality of life measures coming out right now that do though still show those relationships. So something to be thinking about. And then at least one study has shown intelligence can be a concern regarding, scores on intelligence tests can be lower in this population. Again, we're dealing with small sample sizes, so we're going to see variability. I've put some really great guidelines and position papers up here, just some screenshots for you to see that have been published in the past few years by some reputable colleagues. And I really recommend, especially if you're an audiologist, taking a look at these. I have copies of them. They're available on PubMed or your library system that you might have through your work. I'm happy to help distribute them as well. Essentially, these are the guidelines and suggested management techniques for this population. So one of the things that I mentioned previously is that I didn't want to focus too much on all that information I just showed. And part of that is we see over and over again that there's difficulties shown among this population, but we don't really have solutions yet, right? So we find that some children do really well with hearing aids, others don't. Some might do really well with the contralateral routing of signal system or a CROS, C-R-O-S signal, and others don't. Some might use a bone conduction device. Recently, we're seeing a lot more uptake of cochlear implants in this population, but we're still gathering evidence. And so I don't want to focus so much on what we don't know, because we don't know a lot. I want to focus more on what we do know and kind of take a look at more of the qualitative data as opposed to the quantitative data. So the first paper or information I wanted to share is a paper that came out of the UK. It's titled Exploring How Parents of Children with Unilateral Hearing Loss Make Habilitation Decisions, a qualitative study. So a couple pieces of literature that I'm going to share with you today and kind of walk through really focus on the parents and the families. The reason I want to look at that is because we have a lot of inconsistencies in the literature, or maybe not enough evidence to guide, yes, you should do this, no, you shouldn't do that, this is going to definitely help your child. I want to focus on what we can provide. And in order to do that, I want to really focus and learn about what are the families need and what is their experience. So this study is adopted qualitative methods to figure out what are the influences that drive parents' decision making when their child is diagnosed with a unilateral hearing loss, and specifically decision making regarding whether or not to pursue hearing aid, a cross signal, a bone conduction device, a cochlear implant, anything like that. So this group excuse me, this group interviewed 21 families about their experiences through the process of decision making regarding their children's habilitation. They also, all of these children had unilateral hearing loss. They were varying in age, the children, from 4 months to 16 years old. A lot of them have been diagnosed earlier because of the provision of universal newborn hearing screening. And there's actually 2 data sets that they looked at. So they collected some interview information or data from a set of parents in 2016, and then a little bit later, a couple years later. And it's helpful to know that because the information that the analyses that they do and the conclusions they draw are going to be based on 2 different, subsets of the population across time. So that helps us with the reliability of our data and being able to draw firmer conclusions from there. So what they did is they had these semi-structured interviews, meaning they all got the same questions. The people that conducted the study are all very well-trained in qualitative methodology, so interviews for research. They essentially kind of coded all the data and then did a very systematic, what we call a thematic analysis. So they looked at the themes of the answers to the questions that the families gave. And then they organized these themes according to a paradigm that can develop an explanatory framework that would account for variability among those themes and the answers that were given. And it would help summarize the decision-making process in a more, in like a scientific manner, but that is using all of the information that you're getting from the parents, from these families. And so the figure that I'm going to share here, I'll walk you through it, kind of talks about and guides us. It's basically the framework that they developed from the information that the parents were giving. So this explanatory framework of family decision-making describes key features of that process. This process is organized into themes referring to core beliefs, attitudes, and existing circumstances that characterize the viewpoint through which a decision is made. So essentially, and let me get my whole thingy here. There we go. What they found was the core process through this decision making was surrounding negotiating a new normal. So the majority, if not all of these children, were born to parents who have typical hearing in both ears. So the parents were not expecting a diagnosis of unilateral hearing loss or hearing loss in general. So a lot of the process of them making the decision about what to do next kind of teetered on how are they navigating this new normal. And normal was different for everyone. And I'll kind of talk about that a little bit. So normal could mean, for instance, I want my child to be able to have access to sound coming from both ears because I consider that normal. It could also, on the flip side, mean I don't want to give my child an amplification device because I don't want it to be pointed out. I want them to look normal. I don't want them to have a device. So that varied, but the whole process kind of centered around that. There was balance that shifted on this, point of negotiating the new normal between autonomy for the child and then the parents' internal feelings surrounding the hearing loss diagnosis. So autonomy in terms of, I have to make a decision right now, but what if my child doesn't want that decision that I've made for them when they grow up in a few years, in a couple years, versus I feel bad about this. I want to give my child, X, Y, and Z. And so making a decision based on that. So they're constantly balancing the child versus their own kind of beliefs and feelings and considerations, all while trying to negotiate this new normal that they didn't imagine. Some factors that are being considered throughout this process, they determined and kind of analyzed into 4 different themes. One was being passive in the face of the system, meaning that they're a patient, they're going through the EDI system, and they may not feel like they have a lot of control all the time. Information seeking behavior. So now I know that this is the case, and I'm going to try and get all the information I can to navigate this new normal and then figure out what to do. There was also a theme of needing to be deaf enough. So this conflict between, well, my child has normal hearing in one ear, so I think they should be fine. I don't want to do anything to compromise that or to make them disabled. There was a lot of discussion about doing something would then make it a disability, whereas they perceived not doing anything would continue to keep them as normal. And then navigating and seeking out support from different networks. That included parent to parent, community resources, things like that you would think of as Patten, Hands and Voices, things like that. So that is kind of the framework that they came up with regarding the decision-making process. And I will note that this is unfortunately the first study that's been done like this in this population. So we have a lot of work to do, right? We've been focusing so much on the child's behavior, how they perform on this measure and that measure, and what happens if we tweak this or tweak that. But we're really not taking a look at the experience of the family. So some summary points from that study. One of the biggest things that they talked about was that the parents described this as an iterative process. So they were continuously cycling through all levels of this decision-making process. And so it's not that they make a decision about unilateral hearing loss and that's it, that's for good, that's what we're doing. Then the next step comes like this, right? It's not sequential, it's not linear. And that's a really big, I think, shift for a lot of clinicians and providers, that to kind of not think of it as we got to do this now, and then we'll do this thing next, and then the following step. It's more of an iterative process, and they're going to be cycling throughout the entire time. This process is a product of continuously assessing your child's progress over time. So what they might be doing or be able to do in infancy might be different from in 6 months when they're starting to acquire those first, or excuse me, in 6 to 12 months maybe, acquire those first few words and kind of continuing on down that line. So looking at the child's progress over time, we want to be able to make decisions at different points across that time. The parents integrated information from their own observations of their child, the guidance of professionals, and then once the child was old enough, their own opinions. So there might have been some children here in this study where the parents made the decision to pursue amplification, and then maybe the child didn't use it as much at a certain point. One key point was that this iterative assessment, or this process that the parents were going through, was really shaped by what options they were perceived to have been given when they were given the diagnosis. So when that audiologist diagnosed the child with unilateral hearing loss, whatever options they presented at that time, the parents deemed to really shape their process of making that decision. And then the next one that I want to dive into, it was also published last year from a group in Australia, and it's titled Decision Making Following Identification of an Infant's Unilateral Hearing Loss. And this one was really interesting because it not only looked at the parent's perspective, it also looked at the professional perspective. So the aims for this study were to understand the decision-making process of parents when they were making informed decisions about the management that they were going to do for unilateral hearing loss. And then also what the clinician or the audiologist's perspective was on how they were able to support the parents' decision-making process. They interviewed 15 parents of children. All these children had unilateral hearing loss, and they were under the age of 4, so they were fairly early identified relative to what would have been the case in the past. So all these children were identified before the age of 4 with unilateral hearing loss through the newborn hearing screening. They also interviewed 14 clinicians that work with families through that identification process. And again, this is qualitative methodology. So we're looking at semi-structured interviews between the researchers and the parents, or the researchers and the clinicians, and then applying a thematic analysis. So looking at the themes, a very scientific way of analyzing this kind of data. So responses from the participants in the interviews. They found 3 main themes that captured the decision-making process following early identification of unilateral hearing loss. And the big thing I will say up front, which I don't think will come as a surprise, is that confusion and uncertainty dominated the decision-making about habilitation. There was a lot of mixed messaging from different professionals about what was effective and what to do next. And that's what we know. That comes from that variability in the data showing outcomes in this population that I talked about in the beginning. So the 3 main themes The first was motivation for decision making. And to kind of look at that a little bit deeper, 2 sub-themes were identified under that motivation for decision making. One were the parent-centered motivations, and they involved seeking normal and doing something about it. So kind of similar to what we saw with the previous study, the parents were going through this process of trying to figure out what the new normal was for them. And again, we see that normal is different for everyone. It can be normal hearing in both ears or no devices on both ears. So that's going to be different for each parent or family. And then this ability to do something about it. So they really felt like this, they reported this instinctive kind of fire, like, well, I got to do something about it. And that was those were the 2 themes of parent-centered motivations that they found. One thing to note under this is that parents also, under that doing something about it, they often cited that because there's a trial period involved in pursuing amplification, that really, relatively speaking, has no financial disadvantage. Maybe there's sometimes, but not substantial, that doing something became like well, why wouldn't I? If I can try it and we can give it back if it doesn't work, why wouldn't we do something about it? And so that's something to kind of think about as a clinician. So this is a quote from one of the parents that kind of captured these areas. So I think even though we don't have any evidence for it, it's like, well, can you do something or not do something? To aid a child, you're actually making a positive step towards doing something for them. Whereas when you're not aiding them, I feel like you're maybe not giving them every opportunity. So that was just one parent's response or reflection on their motivation to do something. The second sub-theme under here were child-centered motivations. And these revolved around benefits of binaural hearing. So for instance, the parent would report, I worry about localization of sound when she's riding a bike and crossing a road. So being cautious, being afraid of the safety factor, for instance. Another child-centered motivation was that to help them achieve age-appropriate language outcomes. And a quote under this motivation from a parent, providing the best opportunity for our child to succeed in her speech and language development. So that was part of their motivation to pursue amplification. Another one, so a sub-theme of listening and learning. And a parent quote, at school, I didn't want him to come home and say he couldn't hear the teacher or he couldn't hear whoever because it wasn't loud enough. I don't want him to get left behind. And then social emotional well-being. One parent reported, I just want him to be a happy and confident kid. So those are some themes about the motivation for making a decision regarding amplification. So that was our first motivation for decision making. The second theme that was captured was limited evidence creates uncertainty. So let's look at that a little bit more. So there were three sub-themes in the responses here. The first is regarding uncertainty about outcomes. So parents reported inconsistent recommendations following identification that increased their uncertainty about 1, outcomes, and then 2, about the options for management. So they also had uncertainty about timing of intervention. And I think this bears out quite a bit in the past, probably 10 years in this area of literature, is that, with kids with bilateral hearing loss, where we have data to guide this process from early intervention. So we know there's data showing that if we identify early on and the family wants to pursue spoken language, spoken communication, oral communication, that they're going to have the best outcomes if we intervene by 6 months of age. We don't have those data to guide us for the case of unilateral hearing loss, or what people might call single-sided deafness. And so this really influences the clinician's ability to provide certainty or confidence in, yes, I know that your child is going to do great with this intervention or that intervention. And I know that they're going to do great if we start it now versus later. So we really don't have that guidance in the clinical documentation and in the literature. And so this uncertainty then influences the parents' uncertainty and ability to make those decisions for their family. One thing that did stick out from the interviews was that parents reported feeling that there was kind of this dichotomous binary decision that they had to make, either do a device or not. And again, that's inconsistent with what we know from the previous study, and probably just bearing out with experience that what's good for today might not be the best for tomorrow or in 5 years down the road. We need to constantly be analyzing and assessing, integrating our observations, formal assessments, et cetera, to determine what's best at a given time. And so the kind of recommendation from that is to try not to impart this feeling of you have to do it now. It's either you do a device or you don't, because really I don't think that is the case. I guess that's my professional opinion, influenced by these kind of findings and then the clinical guidance procedures that we have noted as well. All right, so some quotes under uncertainty about outcomes. So this is from a clinician, actually. It's hard because parents want to know if everything is going to be, normal. And I guess research-wise, it's really hard to say exactly what kind of outcomes they're going to. Like, there's no kind of conclusive research to say they're going to have X, Y, and Z problems. So this is what clinicians are dealing with. And it's really challenging to guide any shared, informed decision-making with a family when this is what you have in the research. And then another clinician, if there was a concrete research to say either way, what was a better option, which was not, because I know outcomes are so variable, I don't feel like I have any answers for parents with a child who has unilateral hearing loss. Under the uncertainty about options for management, this is a clinician quote as well. We don't really have a clear recommendation for them. So we probably put a lot back on them, meaning the parents, and probably expect them to make a whole lot of sense out of information that probably wouldn't make much sense to them. So we're aware, right, that this is a problem, and we're kind of at a loss for what to do about it. And then this is from a parent. So, I mean, to be honest, to be brutally honest, there has been no management plan. Basically just wait and see, come back, and hearing checks of the ear or both ears every 6 to 12 months. So for that parent, they felt that management plan is not enough. I need more. And then regarding the uncertainty about timing of interventions from a clinician, if amplification is indicated, then I think it should be tried robustly. Another clinician, there is no way of knowing which children are going to have those difficulties later and those who manage well with other strategies. So again, we have a lot of uncertainty regarding because of limited evidence. That was our second main theme captured regarding the decision-making process. The third main theme was available evidence builds certainty, excuse me. So limited evidence creates uncertainty and available evidence builds certainty. So what is the available evidence that parents and clinicians cited? The ability to consult with experts. So that could mean the audiologist, the ear, nose, and throat physician, and the early intervention team. So a speech language pathologist, even a social worker or a counselor, someone who's maybe a third party who can just validate and validate that the parent is doing the right thing by grabbing all this information, taking time to weigh the outcomes and doing the best with what we have. That was something that was cited as a very important factor. There was also parents who reported that a teacher of the deaf or hard of hearing was a really helpful support and guiding and facilitating that interaction between clinic and the education team, and talked about how that was an extremely valuable resource. So kind of bringing more professionals in apart from just the audiologists or the ENT that can maybe shed some light based on their experiences or other things that they know from the evidence. Written resources. So reputable, critically evaluated resources that can supplement what the parent is getting at the appointments. One parent wrote that they were kind of looking on their own and came to the conclusion that the research for bilateral hearing loss tells us that the earlier you start, the better. So we figured that maybe it would be the same. And that family decided to pursue amplification in infancy. And then the value of lived experience. So this could be through connecting parents with other parents, connecting them through parent to parent, hands and voices, all those great support community organizations we have. There can be online support groups that they can consult, the community. And then I'm in the EDDI conference this week, and they were talking about hearingfirst.org, and they have a lot of updated information recently. So hearingfirst.org is a really great resource, very reputable as well. So what are some recommendations? I talked about kind of like the gloom and doom of we have it's really gray. Like we don't know exactly what to do with every kid that ends up having unilateral hearing loss. I think there are some things that we can do though, right? So we're as clinicians, so I'm coming from a clinician point of view and a person who trains future clinicians, that we're charged with helping families make informed decisions. And we hope that that's going to be a shared decision-making process where there's a back and forth of information. We're taking into account the parents' views, values, perspectives, and it's a give and take. It's not a one-sided decision-making process. We want to be emotionally responsive. We want to provide feasible, researched options. And in the case of pediatric unilateral hearing loss, that's really challenging right now for a variety of reasons. So some recommendations: we can try to avoid a dichotomous or a binary approach that you have to do this now or you can never do it in the future. I think that is one big take home. And it's something that in talking with parents who have gone through this process, I've learned that one of the biggest things that they disliked the most about the whole diagnostic process was never being given all of the options, and then not being told that they could change their mind later on if it didn't work out. This also touches on considering the ethical implications of our practice and our own biases. So sometimes we might feel as clinicians or providers that this is definitely going to be the best approach, right? And we have to be careful with that because, especially in the name of family-centered care, what's great for us might not be great for a given family. So just something to kind of reflect on maybe after this session. And then looking at both of these studies, thinking about how this decision-making process is iterative. It's not a one size fits all. It's not a, we do this today and we don't look back, right? It's going to be a continuous process. We want to provide, not overwhelm, but provide families with critically evaluated and balanced information. And that's where it's really helpful to not just be, giving them everything from our perspective, but having them talk to other providers, connecting them with other parents and families who have gone through or are going through similar situations. Assisting with understanding the potential outcomes. And this is part of what makes shared decision-making with this population really challenging, because there's a lot of different potential outcomes. I think starting with reviewing the guidelines and the practice position statements can be really helpful. So they have, outlined based on the evidence, a child who is born with a profound unilateral hearing loss could be a candidate for X, Y, or Z. And this is what you might consider in assessing those different options. Connecting with other families, other experts. And then one thing that is coming up, I think, hopefully in the near future, is patient decision aids or shared decision-making aids that can systematically provide us a tool to help us in this process with our families. So it's not, so kind of just, we do what we can and we do the best that we can without any formal guidance. It kind of helps us with this process with our families. Based on the recommendations provided from these clinical practice guidelines, it's been recommended so for these children, especially in the case where we might not provide amplification or any kind of device in infancy. So families who might elect not to, or families who might not be able to do that for eligibility and criteria reasons. We want to be expanding our toolbox. So outside of just like audiology and hearing, thinking about what are some screening measures and tools that we can use to identify listening or speech and language concerns early on, and not just keeping those for ourselves. So we can share those with families, we can share those with teachers, other professionals involved in the child's care, and not in a necessarily a diagnostic way, but just kind of a, hey, these are some things to look out for. If you see this, it might be time to, contact the SLP, get another evaluation, et cetera. So just kind of giving that information and awareness so that it becomes something they think about, right? And then becoming familiar with the developmental tools that are used for screening in the pediatrician's office. So the American Academy of Pediatrics, you can look up their Bright Futures monitoring schedule and what they're kind of using to think about and screen for any listening difficulties or concerns in the well check visits up through about age 4, I think it is. And it's something to be kind of, well, sorry, I was thinking about relative to the EDDI system. So those developmental monitorings are going to be happening throughout life of the child, but I'm specifically thinking about hearing screening. But kind of getting familiar with those things so that you can be aware of what's being monitored by other people. And then also kind of that can help you fill in some gaps maybe. Early intervention. So I think a lot of times a family might not elect to continue with EI services in the case of a unilateral hearing loss. And it might be really critical for us, the team, people involved in that child's care, to stress the importance of very close monitoring, especially through those first few years of speech and language milestones, auditory milestones, because the difficulties this population might face can be very subtle, especially in the beginning, but then they might creep up a little bit later down the road. So the more kind of on it that we are, I think maybe that can help as well. And then any coaching to facilitate development. So this involves, I mean, early interventionists are doing this all the time. This is the bread and butter of what they do, right? So facilitating all of that development through, speaking to a child a certain way. It's the communication strategies are critical. I always tell my students that one of the best things I did during grad school was I got to observe a classroom for the deaf and hard of hearing. And I had no idea that there were optimal communication strategies in general. And I remember specifically coming back and saying, why don't we all talk that way? Like, that just makes so much sense. So it's just kind of a reminder. I share that as a reminder that it doesn't come second nature to everyone. And so in the case of a child with unilateral hearing loss who may or may not show these subtle difficulties, that really intentional coaching to facilitate that development, hopefully through intervention, right, or early intervention, is really key. And so just kind of promoting that and informing patients and families about that, I think can go a long way. So that's all I have for everyone today. I'm happy to chat and have a discussion, answer any questions if there are any.
Anyone wants to turn their camera on if you have any questions. I'm going to put the survey form in the chat for everyone. You guys could just go ahead and click on that, and then I will enter the code. Dr. Corbin, thank you, thank you, thank you.
Thank you.
Appreciate you spending an hour with us at the end of your day. Oh yeah, and the questions can be typed into the chat too if you'd like to do that. That's an option if anyone has any questions.
And I wish I had put that on my slide. So EDDI is early hearing. I'm writing it in here for you also. Detection and intervention program. And that is the system that kind of under which we have universal newborn hearing screening, early intervention services for children who are, well, children who qualify for a variety of reasons, but specifically when we're talking about hearing loss, children and families so that they can get the support they need to foster development in their child.
This is Sue Ann. We also have a question from Catherine. It says, what is the research around literacy outcomes for this population, especially grade 3 and beyond?
That's a great question, Catherine. There isn't, I feel like it's unbelievable, but it's honestly the truth. There isn't a ton out there. I know of at least one study showing auditory comprehension and reading comprehension can be a little bit, I don't like to say, they can be at risk for this population. And so that's something to be kind of mindful of, and thinking about all the skills that support literacy and comprehension. I think making sure that we're scaffolding those skills really critically early on helps with those literacy outcomes, just like with any child. But I can't really cite, like, I can't think of a specific study to say, yes, this is what they found regarding literacy. I do know that's a thing that can be affected, though. That's a great question.
Okay, if there are no further questions, I guess we will allow you to go and enjoy your evening. So
Thank you so much
everyone.
for having me.
Yeah, thank you everyone for joining us today. Thank you, Dr. Corbin. Thank you, Jesse, our interpreter. We really appreciate everyone being here today. So everyone have a great weekend and St. Patrick's Day celebration if you celebrate. And we'll see y'all later.